Welcome to our second presentation for our PD 201 webinar series. Today, we are going to be hearing from Tammy Evanow. She is our psychiatric nurse practitioner here at NNI. Some of you might know her or might have heard her speak before. So we're really excited to have her on today talking about mental health and Parkinson's disease. I'm going to let her get started here in just a second. So if you have any questions throughout the webinar, feel free to go on and type those questions out in the chat or the question box down at the bottom of your Zoom. You can type those out throughout the program and then we will look at them at the end. Or you can feel free to write some in at the very end. We'll have time for question and answer. So at this time, I'm going to go on and let Tammy get on here and get her PowerPoint up and get started. And yep, there she is. So we're going to get started. Thanks so much, Tammy.
Uh-huh. All right. I'm going to pull this up here and you guys let me know for sure if everything's working okay. Can you see this okay?
Yes, we can see it. We're
Okay.
good.
All right. Well, thanks for having me today. I appreciate the opportunity to be able to talk with everybody. And thanks for the welcome. As Andy said, my name's Tammy Evanow. I'm a psychiatric nurse practitioner. I work here at the Norton Neuroscience Institute, primarily with the memory clinic and the movement disorder clinic. I don't take the place of the medical providers, but I serve as kind of an adjunct service for patients that are parts of those clinics to be able to address some of what we would call the neuropsychiatric symptoms that often accompany persons that are living with mild cognitive impairment, dementia in various forms, and Parkinson's disease. And I've had the wonderful opportunity to collaborate with more with the movement clinic with Dr. Crowell and Dr. Phillips and Zaviera over the last couple of years. And so hopefully some of the things that we'll talk about today will be helpful to understand some of the, again, what we call neuropsychiatric symptoms or non-motor symptoms related to Parkinson's disease. So let me go ahead and get started for you. And again, if I trigger something that's a question for you that you might have, don't hesitate to type that in there. So just kind of a quick review. Parkinson's disease occurs when the brain cells that make dopamine, a chemical that helps to coordinate movement in the brain, kind of stop working or just die off. And so if you kind of look at this diagram, you'll see kind of the difference in the top little, what we call there, the synaptic area, the little area in between that's white, where there's lots of little green dots, that would be dopamine. And when there is Parkinson's disease that affects the brain, then those dopamine levels are low. And it turns out that dopamine is really, really important, not only for movement, but also to help regulate mood. So we have lots of neurotransmitters that are in our brain that help to kind of regulate mood, one of which is dopamine. Those are kind of what I call the happy brain chemicals. So dopamine helps to enable motivation, helps to regulate learning and pleasure, gives you a sense of kind of determination and a desire to accomplish goals, and to address unmet needs. There's also some other neurotransmitters that are kind of involved in kind of helping us feel good, endorphins. Everybody's probably heard of, well, that can give you like an endorphin rush. If you do something like, I don't know, I always think about riding a roller coaster or something. And endorphins give you a release of kind of what's called a brief euphoria. Sometimes that can mask physical pain, and it can sometimes be in response to pain or stress that alleviates anxiety and depression because you get that big burst of adrenaline. Oxytocin is also another neurotransmitter that helps us with building a sense of trust and feeling a connection with people and assistance with kind of sustaining relationships. Oxytocin is really important for new mothers as they hold infants, even petting a puppy or a kitten, a pet of some sort. Just that physical interaction and contact can help to release oxytocin. And then, of course, there's serotonin, which most people are probably a little bit more familiar with. And serotonin helps us to feel significant or important amongst other people, and a calm form of accepting yourself with the people around you. So, what are we talking about when we say motor symptoms? That's probably the most common thing that people think about when you talk about Parkinson's disease. Those are the things that are more what we call visible, things that you would see, that you can see externally, like tremor, slowness, stiffness, problems with walking or balance. And those things are pretty evident to people looking from the outside. And a lot of times when you are at an appointment, those are going to be primarily the things that they're going to really focus on as far as talking about how your medication is working and how those motor symptoms are progressing or how they're being managed with the plan that you have in place. But there's a whole other set of symptoms that are kind of what we call the non-motor symptoms, which are sometimes thought of as being invisible. They're not as obvious to other people. Because part of your nervous system, which is known as the autonomic nervous system, is affected and impacted by Parkinson's disease, a lot of times people will experience these symptoms of constipation, fluctuations in blood pressure, some sexual dysfunction issues. They'll feel sweaty, or a lot of times people will say, I'm cold all the time, or I feel like I can't warm myself up. I get hot and then I get cold. And then also difficulties with urination, frequency, especially sometimes at nighttime. And then mood and thinking. So, non-motor symptom as far as what we would fall more into kind of like the neuropsychiatric realm, memory and cognition. And when we talk about cognition, that is really kind of more than just your memory. Cognition has to do with how you think and how you organize your thoughts and how you plan and put things in sequence and how you utilize judgment and insight. So it is more than just memory. And I know sometimes we use those words kind of memory and cognition, and it's not always clear exactly what we're referring to. So cognition is more than just memory. Depression and anxiety is also something that's probably very common for people. And apathy is also very common. And if you think back about what we said dopamine does, it helps with motivation and accomplishing goals. Apathy is something that we'll talk about in a little bit more depth coming up here. But if your dopamine levels are low, then you're really more at risk for being more apathetic. People can also experience psychosis, primarily in the form of visual hallucinations, and then difficulty with sleeping, disrupted sleep. Other physical changes that you might experience can include drooling or runny nose. I often get lots of complaints about, I don't know what's wrong. I've got a runny nose. I just feel like I've got allergies all the time. That's also kind of related to some autonomic nervous system issues. Excessive daytime sleepiness or fatigue. A lot of people complain about pain. Now, Parkinson's disease itself is not really considered a disease process that causes pain, but Lack of movement can make you stiff. Your joints can be, more stiff. I know myself, if I sit for a long time without bending my knees, then I get stiff. But pain is certainly something that can be experienced by people with Parkinson's disease. And I have had some people say my muscles just feel like they ache. Um, Skin changes, sleep problems, loss of smell, speech and swallowing problems, changes with vision, and then obviously changes with weight, frequently related to swallowing problems or sometimes nausea from some of the medications that are used to treat the movement disorders. So I really like this little diagram here. It's kind of busy, but if you look at it, if you look to the far right and look up to the top of it where it says prodromal Parkinson's disease. Now, what that means is prodromal is typically things that are starting to happen before you actually kind of meet the criteria for or actually have a diagnosis of Parkinson's disease. And these things, if you look at the very bottom, it says time is in years. So this is a period of years. So look at the very first thing. The very first thing is disruption of sleep or this REM sleep behavior disorder. And a lot of times people have this disrupted sleep for years before they have any idea that that can be related to what's kind of coming down the road, which is going to be a diagnosis of Parkinson's disease. And the depression and anxiety also, and constipation, also are things that typically occur way before you actually have an onset of some of the motor symptoms. So it is not uncommon for people to go to their primary care provider and report some depression and anxiety, kind of feelings of low motivation, because that process of changes in the dopamine has already begun. And it is enough that they begin to notice some changes in their mood as the disease process continues to progress to the point that you will begin to, if you look at the top part of that little arrow thing there, you'll see bradykinesia, rigidity, and tremor. And so what that basically means is slowness, stiffness, and tremor. Now you are beginning to have some of the motor symptoms in conjunction with the bottom half of those that are kind of like the more of an olive green color symptoms, those symptoms that are considered the non-motor symptoms. So really, we have to really pay attention to those symptoms because look how much earlier the non-motor symptoms begin to emerge prior to the emergence of actual physical or motor symptoms. And you can see over time, and this is years, and there's not any set years, which is why there's not any designation at the bottom as far as how many years, because everybody is different. Everybody responds to the progression of disease differently. People respond to medication differently, their tolerance and their, dare I say, even the provider that's providing treatment for them, what their skill level is, and how quickly they pick up on what your diagnostics would indicate that you need as far as treatment for your diagnosis, which would ultimately be Parkinson's disease. How early do you get that diagnosis and start doing things that can slow the progression of the disease process and get started on medication that's going to be helpful for minimizing those motor symptoms. So as those non-motor symptoms progress, you'll see that there's fatigue and pain and apathy and some mild cognitive impairment. The urinary symptoms, orthostatic hypotension, which is fluctuations in blood pressure, particularly when changing positions from lying down to sitting up or sitting to standing. You have drops in blood pressure, and that can be pretty dangerous for people. You can have your blood pressure drop really low, and you get kind of lightheaded, and can result in a fall. Then there are also the psychotic symptoms. Typically, I said, come in the form of visual hallucinations. And then in the very late stages of dementia, it is reasonably common for people to develop a dementia. And there are various stages of dementia. That does not necessarily mean that you're going to be in an advanced stage of dementia at that time. So I don't want that to frighten you. So what are the most common mental health concerns that I hear about? Changes in mood are the most common. Depression, obviously, this is a chronic illness. It is a lot to adjust to. A new diagnosis, we would anticipate that you're going to experience sadness. Difficulty adjusting to a diagnosis, and how's that going to impact my life, my family's life, those people around me that care for me. And we define depression as kind of sadness or dysphoria, sometimes is the word that you may hear. You might have feelings of guilt or feel hopeless about your future. And typically that occurs in about 50% of people that have Parkinson's disease. If I had to pick, I would say the number one thing that people describe to me that they struggle with is a feeling of anxiety. And that can come in various forms. It can be kind of a generalized anxiety, kind of feelings of panic or social anxiety. I just kind of feel off, kind of an internal sense of kind of vibration. I feel like I'm just like vibrating on the inside. I just feel like everything is all shaky. Even though I look like I'm not shaking on the outside, on the inside, I do feel that way. And then there's also something called impulsive compulsive behaviors, which I kind of lump into the category a little bit of anxiety, although it is a little bit different, and it is related directly to levels of dopamine in some of the medications that we use to help manage the motor symptoms. So this little graph is one of the most important things that I try to teach people. So we do have some great medications to utilize to treat the motor symptoms, and Dr. Crowell and Dr. Phillips and Zaviera are excellent at managing those medications. But it is really important to try to maintain a routine and some consistency when you're using those medications. Some of them, unfortunately, don't last for a long time. They begin to wear off. And when people have that wearing off period, it's kind of like you feel like you're kind of falling off of a cliff. So if we look at this line that runs across the this graph here, that's going to represent time. And if we look at the green line there and look at the very bottom where it says PD medication. So let's say, for instance, that is when you take your medication. I'm going to try to use this pointer. I don't know if you all can see this pointer or not, but I'll try to describe verbally what I'm saying also. So if you take your Parkinson's medications at this time, then they're going to kick in and they're going to begin to work, and they're going to provide you some symptom relief as far as definitely motor symptoms, and very likely some of the non-motor symptoms as well, because you are supplementing your body essentially with dopamine to help with movement. Now, as those medications begin to wear off, and it's about time to begin to take the next dose of medication, you'll see that those symptoms begin to return. It's kind of like going down a little bit of a sliding board. And then when you're back down here at the bottom again, it's time to take the medication again. Um, and that is kind of the period that we call a wearing off period. And that may be the time that you noticed a recurrence of physical symptoms like motor symptoms like feeling stiff or tremor or however that manifests itself for you in particular. So it's time to take medication again. Then it's going to kick back in again and then it's going to work. So the name of the game is going to be trying to keep this green little squiggly line here as flat as possible, not letting it go for long periods of time between your doses of medication. And that is a very fine art and a skill that the medical providers can utilize to work with you to figure out how can we kind of compress this green line as efficiently as possible. How can we utilize these medications? What is the timing that we can use? What dose can we use? If it's wearing off too soon, but if I give you more, then you have more side effects. Is there something I can augment that with to get better control of those symptoms and stretch those periods out? So I think this is a really good visualization for people to understand. That a lot of times when people are talking with me about the anxiety that they're experiencing, when we talk a little bit more about where that comes from, frequently that anxiety comes from that period of time where there is some wearing off. Or maybe the evening dose of medication, you take it earlier in the evening and then sleep all night long, and then you wake up essentially with no medication left in your system. I call that waking up on an empty tank. It's kind of like you got to think about yourself like a car, and you got to keep gas in the car to keep it running. And if you don't put enough gas in it at nighttime to keep it running, then when you wake up in the morning, you're going to be on an empty tank. So frequently people will complain about anxiety in the morning, just feeling off. And so there are all kinds of strategies that we can utilize to try to compress that green line a little bit to minimize anxiety that is really related closely to levels of dopamine. Now, we talked a little bit as well about apathy, which is different from depression. So, apathy occurs in about 33% of people with Parkinson's disease, and it involves difficulty initiating tasks, a lack of motivation, and effort to complete things. I kind of do that all the time. I'll start things and don't finish it. Um, you need frequent prompting or reminding from other people to complete a task or kind of encouragement to finish something. It looks a lot like depression, but you may not have any impact upon your mood. So the difference between apathy and depression primarily is your subjective report of your mood. Nobody can tell you that you're depressed. Only you can. Now, the way you look to other people is actually called your affect. That's how you present yourself to other people. Now, you might look like you're sad to other people, and sometimes that is impacted by some of the physical changes that go along in your facial expression that is related to some of the motor symptoms of Parkinson's disease. And so to other people, you might not smile as spontaneously or look as animated as you did. And their interpretation is that you're down or sad. But frequently, people that are struggling with apathy are really just kind of content. They're not really sad. We're just inferring that they're sad because they're not doing all of the things that maybe they used to do. So remember that apathy is a symptom of Parkinson's disease. And the person that is dealing with Parkinson's disease is not lazy or making excuses. It truly is a neurophysiological issue that's related to some of those neurotransmitters in the body. Memory and cognition also occurs in about 50% of people with Parkinson's disease. Again, there are various levels of impairment. And this little, I don't, I was terrible in geography. I don't know what kind of shape that is, but it's kind of cool looking, isn't it? Whatever those pretty colors are, those are kind of the things that are involved in cognition and memory. Executive thinking, that's kind of the planning and organizing. I like to call that's your brain's secretary. Tells you what's on your calendar for the day, reminds you about things, keeps things in order and flowing. It's time to take your medicine. You have appointments today. You have to take a shower. You have to kind of puts things, organizes them for your day. Your attention, your ability to focus, use of language and visual spatial perceptions, how you see things and how that's communicated to your brain. All of those things are involved in memory and cognitive issues. So you can be easier, just more easily distracted. It's harder to focus or concentrate. And again, that's related to some of those changes in the neurotransmitters that help with concentration and focus. It's harder to multitask. Frequently, I will tell people you may have been able to juggle 15 things at one time in the past. For myself, I think about times in my life when I was raising small children and I was on the phone talking to my mother, making sure everything was okay at her house, and then cooking, and then having laundry going, and getting kids sitting at the table doing homework, and letting the dog out. And I was doing all those things at one time. I don't think I could do that anymore. In fact, I'm sure I cannot. So, instead of all of those things being juggling at one time, I might be able to more easily juggle maybe five things at this time, not 15. Slower processing, being able to receive information, process it, understand what the task is or that you're being asked to do. Troubles with language, sometimes difficulty remembering people's names or pulling a word out, remembering the name for an object or things, and then poor concentration and attention. Hallucinations are also something that are pretty common. Occurs in about 20 to 40% of people that have Parkinson's disease. It can be related to the disease process itself. It can also be related to the use of medications that help with movement. We know that people that have schizophrenia have high levels of dopamine. And so typically they would struggle more with higher levels of dopamine associated with visual hallucinations. We treat them by giving them medication to try to lower those levels of dopamine. And we have to be really careful when we do that because if we lower it too much, then guess what? We cause them to have symptoms that are very similar to Parkinson's disease because we've actually lowered the dopamine a little bit too low. So there's a fine line with trying to find a medication to manage symptoms without creating too much of a side effect for the person. So essentially, it's just the flip flop for folks that have Parkinson's disease. We're trying to give you medication that's going to help to increase dopamine, but that can have an impact upon your visual interpretation of things in the environment. So you can experience hallucinations and something called illusions. They can occur in the form of visual, auditory, tactile, which is feeling things, your sense, and then presence. And that is also something that's pretty common. Now, if you look at this little diagram here to the left, or to the, well, yeah, it's to the right, I guess. I'm trying to think which way you all are facing to. So if we look at the very top, things that are very minor that frequently occur, minor illusions. So an illusion means there is typically something really there, but you kind of just misinterpret it. A hallucination is something that's not there. So a minor illusion might be something like a hallucination of passing, where you feel like somebody, you kind of just out of the corner of your eye see something go past you. Maybe was that a person in the corner of my eye, or was that a dog or a cat or something running across the floor? There are also the illusions, and I don't know, that's kind of a weird thing there with a cat. I guess that's supposed to be a leaf, but I don't think I've ever seen a leaf the size of a cat. But say you looked outside in the yard and saw, I don't know, a shrub or a bush that was kind of tall. And initially, when you first look outside, it looked like a person standing outside. But the longer you look at it, the more you can kind of decipher that it's not really a person, it's really just a shrub or a bush. So that is an example of an illusion. Sometimes people will struggle with depth perception as well. If something looks dark or light, they might have a little bit of difficulty judging the height of a step or something like that. And that's important to know because that can place you at risk for falls if you can't judge height or distance. Hallucinations of presence are when you just sort of have the feeling or the perception that maybe somebody is standing beside you or behind you, or that maybe I've heard people say that they feel like somebody sits down next to them on the couch or is lying next to them in bed. And then diplopia is when you see two of something. You kind of have that experience where there's two of something, and it's difficult to kind of write that. There are some referrals that we can sometimes make for some prism glasses. If that is something that people are struggling with, that can help with some of those experiences. Now, a thing that is really important is how much insight do you have into these experiences? So if you just feel like something's kind of walking past you and you look and say, oh, I thought I saw something there for a minute, but you have insight that that experience wasn't real, then that is considered kind of minor. If those things begin to progress and those hallucinations become more real to you and more defined, say, for instance, I don't know what that is. I don't know if it's a cheetah, but it looks like it's got a fox head. I don't know. But if you feel like you're beginning to see something that is more defined, like people or animals, then that can sometimes begin to change if your insight changes. And as the disease progresses and people may experience more changes in cognition, sometimes those things can happen. They will begin to have visual experiences or hallucinations that they have difficulty deciphering if that's real or not real. And sometimes they don't talk about it because it's kind of a scary thing to experience. And you might not feel comfortable sharing that experience with somebody. But one of the things that I always try to do is normalize that for people so that you can understand that that is directly related to some of those changes in neurotransmitters. And it doesn't mean that you are developing schizophrenia. That is not what it is. It is directly related to those neurotransmitters and those experiences visually that you can have. Um, if those experiences and hallucinations persist for a long period of time, then they can cause development of something that we call delusions, which is thinking about things that are not real. But if those like visual hallucinations persist for a while, for example, remember, I gave you the example of a bush outside. If that bush begins to look more like a person over time, and you feel like that person is outside, and then you feel like that person is coming closer to the window, and then the person outside the window is looking inside in your home, and that happens consistently over a period of months to years. Then eventually your brain, which is amazing, is going to start trying to come up with a reason why that's happening. Wonder what they're doing out there looking in my home. They must be up to something that's not good. Otherwise, they would have come in, knocked on the door, introduced themselves. So that can begin to cause people to have what's called fixed false beliefs. And sometimes those things can be more distressing or what we call paranoid, frightening. And that's when people may call the police or tell you about somebody being outside. All of those kinds of scenarios can occur. Changes in sleep is also a big issue, and that occurs in anywhere from 30 to 80% of people with Parkinson's disease. There are various types of sleep disorders. Insomnia is just a word that we use to kind of say, you're not sleeping well. Okay. And there's all kinds of, there's a whole other science just about insomnia and types of insomnia. But initial insomnia is more difficulty falling asleep. And then terminal insomnia is more difficulty sustaining sleep. Or then there's a whole other issue of just waking up early. You can reasonably fall asleep, you can sleep well, but then you just wake up at 4 o'clock or 3 o'clock every morning. Um, the REM sleep behavior disorder is very common for people with Parkinson's, and it's essentially where you act out your dreams. It occurs during REM sleep when you are dreaming, and things that you're dreaming about, your body did not get the memo that you were sleeping. And so you might have really restless sleep. You may talk in your sleep, you may move your arms and legs around a whole lot. And it can be pretty dangerous sometimes for a partner if you have somebody that sleeps in the bed with you. I've had people accidentally get hit or choked or kicked or try to wake the person up, and they're kind of in this dream. And almost without fail, the dreams that people tell me that they have something to do with safety. Either they're trying to run away from somebody or something to protect themselves, or they're trying to protect a family member from something, or they're in a fight, or the police are around, or they're at war, or all kinds of things that are kind of along that vein. But typically, it would be things that are a little bit more distressing. Also, treatment wise, we typically initiate treatment with for that disorder with melatonin, and then kind of consider also referrals to sleep center if sleep breathing disorder is something that you might experience, which is sleep apnea. Restless legs and periodic limb movement disorder is also something that the medical providers can look at. They can look at some of your iron sometimes can impact that. It can be related to certain types of medication, can cause you to be a little bit more restless at night. Um, Medication related issues are also something that can occur for people. You can be really drowsy during the daytime, and sometimes that can be related to certain types of medications that people take. More vivid dreams and kind of an exacerbation of that REM sleep disorder are pretty common with some of the antidepressants that people take. It can disrupt your REM sleep a little bit more. So that's also something that we really kind of look at to see if there's anything we can do to minimize any medications creating side effects or more disruption in your sleep. And then there are actually symptoms that are more motor symptoms, specifically related to Parkinson's disease: stiffness, slowness, cramping. It is not uncommon for people to kind of wake up sometimes in the middle of a dream and they feel a little bit more confused or can't place where they're at immediately. They may even have experiences where they think they see somebody that might have been a part of their dream. Takes just a minute to kind of, right the ship and feel like you're kind of organized and oriented again. Nighttime urination, having to get up and go to the bathroom a lot at night, and excessive sweating at night are also something that are really common. And that is also something that you don't have to just deal with. Frequently, the physicians, the medical providers will make a referral to someone in urology to help look at those issues to see if there's anything that they can do to make that better for you so you can have a more restful sleep at night. Um, so This is a little graph. There's this one website that I really like called Mind My Peelings, and it is created by a consumer. He's actually a patient himself, a consumer of mental health services. And so he likes to utilize this information. So you have a situation that occurs and it creates thoughts, and then you have a reaction, and it all kind of circles itself back. And all of that involves your emotions, your physiological self, which is your body, your physiological self, and then behaviors, which is the way that you manage or the way that you respond to those things. So it starts with some kind of distressing situation or a trigger. Then that can cause you to have negative thoughts. Then those thoughts cause negative emotions and physical distress, which leads to the negative behavior. So, what are some non-pharmacological treatments that I often recommend? Number one is exactly what you're doing right now. Learn as much as you can about the disease process. Learn about things like how can I use my medication most effectively to minimize periods of wearing off, to prevent those things like anxiety or panic. Be open and honest with your provider. Network with other people that are having the same experiences as you are. I know that there were some folks that joined from a support group, and thanks for being here. And what a great way to connect with other people and share your experiences with yourself and loved ones as you deal with this disease on a daily basis. One other thing I was going to say. Oh, be open and honest. We do know that fluctuations in dopamine can cause some symptoms, those ICD behaviors or impulsive compulsive disorder type behaviors that can involve excessive spending of money, gambling, buying, like lottery tickets or excessively doing a hobby of some sort, eating a lot of sweets. It can also cause kind of a hypersexual behavior. And so people can be involved in more viewing of pornography or for some reason just feel like they're more hypersexual and your partner's kind of like, what is going on? Please feel open and honest about being able to talk to us about those things. We're all adults. We all have the same responses to the fluctuations in those neurotransmitters. And we want to make sure that we're providing good care and giving you the best information that you can about those symptoms. So please feel free to be open and honest with us about that. If you don't feel comfortable talking about it, type it in a my chart message and send it to us. So at least we know that that's an experience that you're having and we can address it. Exercise. Exercise is the number one thing that you can do to help yourself feel better emotionally, physically, everything. Even sometimes people will just describe a sense of like, I feel like I'm a spring and I'm really tight, and I just have to get up and do a push up against the wall or walk around or just expel some energy. And once they do that, they'll feel better. So take advantage of the resources that are available in the community and through NNI. Tai Chi, boxing, yoga, stretching, all of the resources that are available. And then you can make lifestyle modifications, prioritize things, and simplify your day. What kinds of things are really important? Maybe if you have three things that you have to accomplish this week, maybe you want to do them all in one day so that you can have the rest of the week to kind of be able to relax and focus on just doing things that are a little more comfortable for you. But maybe doing those three things all at one time in one day is too much for you to do, and you'll wear yourself out and then spend the next 2 days recuperating from everything that you did on Monday. So think about sometimes doing that. What does your routine need to look like? Try to keep some consistency with a routine, have something on your calendar a little bit in every day. Make sure that you rest and take care of yourself. Take a short nap during the day. It will help your body to recuperate for the second half of the day. Don't take naps after 4 o'clock and try not to exceed 45 minutes to an hour for a daily nap. Eat healthy, make sure you drink plenty of water, or beverage of your choice that's relatively helpful, not, carbonated, sugary stuff. But some people don't really like to just drink water. There's lots of flavored waters that you can get, or things that you can put in water to kind of make it a little more palatable. But it is really important to do that. Remember, we mentioned the orthostatic hypotension, which is like if you change positions, your blood pressure can drop. So if you're a little on the dehydrated side, then you're more at risk for those blood pressure fluctuations. So this is how I always try to explain it to people. Everybody's probably held a garden hose at some point, and if you have the water on really strong and you're watering something, if you lay the hose down and you stepped on it, it feels really tight and full, right? But if you just have a little bit of a trickle of water going through the garden hose and you throw it down and you step on it, you can squish it. It doesn't have that same amount of pressure in there. And your body, all those little veins and everything are kind of exactly like that. Your arterial flow and your venous flow of blood is going to be more full the more blood volume that you have. And so that supports your blood pressure more, the more fluid that you have. Um, Make sure that you try to have good sleep hygiene, try to rest, try to be somewhat consistent with your bedtime. And then, if there are any issues that you have with your spirituality, faith, make sure that you reach out in those areas and whatever that looks like for you. And we do have services here at Norton's as well. Reverend Amy's wonderful. So don't hesitate to ask us for resources if that's something that you feel like you'd like to explore more or talk with somebody. Practice relaxation and mindfulness. And you guys, I really do this, I swear. So this bubbles. I don't know if any of you, if I've ever actually seen you, but I frequently give out bubbles. So, this deep breathing and relaxation is a thing. Okay. You want to do that. But if you're like me, I get kind of bent out of shape trying to follow take what's a deep breath for me might not be a deep breath for you. And then if I try to follow some of those apps and stuff, I'm already ready to exhale and they're still taking a breath. And so here's what I recommend. And I really do keep these in my drawer, I give them out pretty frequently. If you can do something that doesn't seem like you're deep breathing and relaxing, something that distracts you in a different way, then you can still accomplish the same goal, but it's more fun, I guess. I don't know. So these are my favorite. I get them from Walgreens. They blow good bubbles. You don't have to stick your finger in the bubbles, and there's a lid so it doesn't drip all over you. And then take a deep breath. Has a lot of bubbles. This is a good one. Oh, see, isn't that great? And I'm not kidding you. It is really a good way to take a deep breath and to exhale and to just really just watch the bubbles and distract yourself. And it is a good way to calm yourself, to calm down the anxiety that sometimes start. Anxiety can take on a life of its own. It's kind of like somebody pulled the fire alarm, but there's not really a fire. But when you pulled the fire alarm, a whole lot of things went into motion, like the big fire alarm is going off, and there's lights flashing, and there's lots of noise, and the fire doors start to slam, and the fire truck is getting started, and the firefighters are putting all the equipment on. And then guess what? It is really just a false alarm. Really, the thing that you're anxious about is not a real thing. You just need to slow that down. But it's hard because how do you stop the things that are going on in your body, just like all the automatic things that are happening when the fire alarm went off? How do you reach out and say, hey, that was just a false alarm? Stop that process that's already happening, the fire truck, the firemen. But taking a deep breath and really focusing on relaxing is a way that your brain can tell your body, hey, that was a false alarm. We really don't need all those things happening, your heart beating really fast and the rush of adrenaline, because we're really fine, we're really okay. And slowing down your breathing and utilizing something as simple as blowing bubbles can tell your brain and your body that it's time to shut that process down and to get back to a calmer sense of state. Keeping a journal is a really good thing. Aromatherapy, I love aromatherapy. I also have that. I have lavender. I love lavender, lavender and citrus. Just even if you're feeling kind of stressed, just taking a little bit of lavender lotion, put it in your hands, kind of just rub your hands, take a little bit of extra time, do that. Just be aware of the scents, of the smell, and the relaxation. Music therapy is also something that's really great. Listen to music that you like. Drumming, they have a drumming class that they do it on Mondays. I always know because I hear everybody upstairs. Acupuncture, massage therapy, therapeutic humor, just like watch funny videos or funny movies or anything that you find enjoyable, and utilize your body's natural endorphins when you laugh. It releases good things in your body. Enjoy nature, get out, make sure you expose yourself to sunlight. Do things that are crafty and might enjoy as far as a hobby. I like to paint rocks. I have a whole bunch here on my desk. You all can't see them, but I'll pick them up for you. So I like to paint little rocks, and my grandsons sometimes collect them for me. And then I take these little rocks and I leave them laying around places for people to find. Anything that's small like that doesn't have to be, a huge, big, fancy thing. And then consider counseling. Counseling can help you to correct negative thinking patterns and behaviors and develop more positive thoughts and learn new coping skills. So, how does that work? All right, so this is an experiment. So I want you to look at this picture. Some of you may have seen this before. So when you look at this, what do you see? Do you see an old lady looking down with a feather in the top of her hair and a scarf on the back of her head? Or do you see a younger lady looking away with a feather in her hair and her nose is kind of facing away? Just take a minute and look at it. Now, whichever one that you did see first, kind of switch it and see if you can see the other one. So, again, I don't know if you all can see my pointer or not, but if this is the younger lady, this is her face, this is the eyelash, and this is her nose, this is her ear, and she's looking away. This is, I don't know, some kind of scarf or something maybe on her head. So that is the younger woman. Now, if you saw the older woman, then this again is her hair, this is a scarf, but this is her nose, and this is her chin, and this is her mouth. Now, did anything change with that picture? No. Not at all. I didn't redraw it. I didn't do anything different to it. But you taught your brain how to see two different things in the same picture. And that is essentially what therapy and counseling does for you in a nutshell. Teaches your brain how to see things differently and allows you to put that in practice to break old habits. There are referrals that we can make for you, suggestions for providers that do have a better understanding of more some of the neurological conditions that people deal with. But there is also a good resource that you can use to find a therapist, which is Psychology Today. And you can just type in your zip code and look for a provider. But we pretty frequently make referrals, and the folks in the resource center can help you with that. Utilize support groups. That's helpful for both patients and care partners. We have support groups here, obviously, in the Resource Center, and then there are also some more national support group options as well. What kinds of pharmacological treatment options are there? First of all, trying to be organized and use planners and try to stay on task and try to keep your medications going as close to possible or close to the same kind of schedule as possible. Minimize polypharmacy. Sometimes other providers are not experts as far as medications and how they can impact Parkinson's disease. So, maintaining a good relationship with your movement specialist is a good way to make sure that any other kinds of medications that are being added for other conditions are something that's going to kind of play well with the Parkinson's disease process and some of the other medications that you might be taking. Streamline providers. Try to make sure that you don't see a whole bunch of different people. Trying to stay within the same healthcare system is sometimes helpful. Certainly, you can go to whatever provider you need, but trying to facilitate and keep those things streamlined as much as possible so that everybody knows what diagnostics and medications that you're utilizing. We've already mentioned taking your medication consistently, using vitamin supplementation, a regular multivitamin, make sure your B vitamins and your D vitamins are good. Vitamin D can get low if you're not exposed to sun. And folks that have Parkinson's disease and take medication for treatment of that are often at risk for needing supplementation for the B vitamins. Sleep agents, as far as things that you can take to help with sleep. And these are some of the things that I frequently would review with somebody to see if this is something that would be appropriate for you. Melatonin for the REM sleep behavior disorder. Sometimes we utilize trazodone. Sometimes we utilize a medication called clonazepam. There are also antipsychotic medications that are used to treat primarily some of the psychotic symptoms that people may experience. Nuplazid, quetiapine, clozapine is also something that can be used, but not as frequently because of some of the more extensive monitoring that has to be done with that. And then there are medications that we use for depression and anxiety. And I kind of really lump those together a little bit because we utilize pretty much the same medications in many ways to treat depression and anxiety because it's the same neurotransmitters. So some of those medicines may be what's called SSRIs or SNRIs. There are some others that kind of fall out of that category. There's another new one. Oh, I do have it on there. Avelti. There is a medication for something called pseudobulbar affect, which is also something that people experience. It's kind of uncontrolled crying or laughing. Gabapentin, buspirone, trazodone, magnesium glycinate, and Calm Aid is also something that magnesium and Calm Aid you can get over the counter. And guess what Calm Aid is? It really is just lavender. Um, Lavender is used in a pill form, and you can get it over the counter or on Amazon. It comes in an 80 milligram tablet. You can start with 80 milligrams once a day and move up to twice a day. It can be very helpful. Clonazepam, lorazepam, and diazepam are also sometimes medications that are used. But again, we try to minimize medications that have potential side effects as much as possible. There are some medications that we can also use for treating apathy, but primarily we want to use something non-pharmacological if possible, even a little bit of caffeine to kind of help boost your energy. And we recommend trying behavioral activation first, which is kind of putting together a little bit of a calendar and trying to stick to that calendar. All right. Well, that kind of got to the end of that. Do you guys have any questions at all that I could maybe answer for you?